Let us go ahead. With that, let us go ahead and get started. I will turn on my video here. And so I'd like to welcome today, as I said, great to have everyone here. I'd like to welcome Dr. Barton Schmitt as our guest today in the final webinar of our 10 for 10 series. Bart is one of the two senior medical editors of the triage protocols that are used in Clear Triage. He is a key figure in the growth of nurse telephone triage to the important role that it plays right now in healthcare. And we are just so glad to have you here. So welcome, Bart.
Thank you, Dave. It's great to be here. I want to make a comment. Been thinking. I finished my pediatric residency in 1966, so next year it'll be 60 years in patient care and teaching pediatrics. I taught a group of pediatric residents this morning earlier. Uh, I've been accused of having medicine as my only hobby. It's true. That's all I wanted to say. It's natural.
Well, that's a great insight. And I think it puts us right on the right path because I think that what I'd like to do today is just talk about your journey from those days to where we are right now and really just some of the steps along the way. So let's wind it all the way back. As you went to college, were you intending to become a doctor? Was that your starting part of your journey here?
It was never on my radar. I was a chemical engineering major. I graduated with that degree. Um, I had my senior thesis. I was doing it on oil shale refining, which was this new and shiny part of chemical engineering. Uh, in October of my senior year in college, started looking for jobs and have recruiters come to campus and got interviews with chemical companies and plastic companies and lots of petroleum companies. So it was really in early November with an interview of Standard Oil of New Jersey, it clicked in my mind that it wasn't going to work for me. There weren't enough people, not enough people contact, and it was too much based in math and chemistry. I wanted more than that, I'm afraid. So I had all my pre-med requirements, except I did not have biology, which wasn't part of chemical engineering. I went to the head of biology department and got permission to start taking biology. So after Thanksgiving, I started in that class
So
and
this is
got,
a class that had been running for 2 months and you jumped into it.
yeah, yeah. But I was an ex-scout, loved nature, collected a lot of things from nature. Anyway, I got special permission to read the biology book over Christmas break and take the test. And if I passed, he would keep me and okay that coursework. I delivered mail on foot, was what I did usually during Christmas holidays because of all the Christmas mail. So I was either delivering mail or reading a biology book. And anyway, it all worked out. I applied to 3 medical schools, got into them, ended up at Cornell Medical School in New York City, Manhattan, 69th in York.
Well, I think the engineering background explains some of the logic behind the protocols, but we can touch on that. But it is, I love that starting point of your medical career. How'd you shift as you entered medicine? How'd you wind up in pediatrics?
I wanted to say I loved, especially the clinical years, the patient experience years in medical school. And medical school was far more, more interesting and eager, easier than residency in engineering. But you're right, it was good background. Um, I was going to be a family physician. That was always on my mind once got into my third year. And I reached a point where I didn't know how I could master it all, at least the level at which I liked to function. And so it was between internal medicine and pediatrics. And you ask any pediatrician, you get the same answer. You start thinking about it's more fun. The people that work in pediatrics have more fun than people who work in especially geriatrics. Uh, and also, it's all the promise that children have. You know, if you save a life, it's a long life. If you prevent a disability, it's for the next, what used to be 60, 70 years in, now it's 80, 90 years. So I enjoyed my teachers and enjoyed that subject matter. It was an easy decision once I was forced to make it.
Many decisions are easy once you're forced to make them. So,
Yeah.
okay. Well, so just again, working our way through a journey. So after you decided to go into pediatrics, you wound up in Colorado and then eventually at Children's Hospital, Colorado. How did that proceed?
That's not a straight path. Um, my pediatric residency started 1963 through 66. And I got into a nice program, a really good program, University of Minnesota Hospitals, Minneapolis, St. Paul. And I loved all my rotations. But by second year, my favorite was pediatric neurology. It was a relatively new field, and the two neurologists that taught it were just great. So I decided to enter that field and got a fellowship lined up at University of Colorado's Department of Pediatrics with Gerhard Nelhaus, a very famous pediatric neurologist. So um, that's how I almost ended up in Colorado, and it was not meant to be. It was 1966, January, I think, that the Vietnam War buildup was occurring, and they were drafting graduating residents left and right, and I got drafted into the Air Force. I was assigned to McClellan Air Force Base outside of Sacramento and was the only pediatrician on the base with approximately 9 or 10 other docs, one internist. The others were, some of them were just out of their internship. Um, so being there, I fell in love with taking care of, being a jack of all trades, master of none. I I took care of all the kids on base. Mainly officers' families lived on base. The docs were all ranked as captain anyway, and the non-enlisted people that lived off base, their children as well. So I just learned a lot. The closest hospital was almost an hour away by ambulance. That was Mather Air Force Base on the other side of Sacramento. So there were times I rolled an ambulance across town with a kid on oxygen and bronchiolitis and cyanotic and so on. And but so I really tried to keep kids out of the hospital. I took care of a lot of things, patients at home that I probably shouldn't have. Anyway, during those good years, and that was probably the easiest years of my life, believe it or not, and the steepest learning curve of my life, I realized my deficit in my training along in med school and residency, and even at that point was in behavioral science and behavioral health. And so I was looked into fellowships again. I by a year into it, I'd canceled the pediatric neurology one, but of interest in the School of Medicine in Denver, Colorado again, the Department of Psychiatry was one of 3 departments in the country that offered a fellowship in psychosomatic aspects of pediatrics. So I signed up for that. I got that, and it was given so it was 68 through 69 with Dr. Dane Prue, who I met with once a week, sometimes twice a week. I worked in the GI clinic, the diabetes clinic, the allergy clinic, the endocrine clinic, the pulmonary clinic. It didn't take much time before the physicians who ran those clinics to send me their most difficult patients. And so I was able to present those to a child psychiatrist every week. It was a great year. for learning all kinds of things. In my spare time, I worked at the neighborhood health center system and ended up loving teaching there because there were residents there. And then the next year, I worked full-time in the neighborhood health center system. And then got recruited by the head of the Department of Pediatrics in 1970 to join the faculty and to start. By the way, I was the 21st hire. There were only 20 people in the faculty back then. Now there's 1,200. I got hired to start a teaching clinic in ambulatory pediatrics. Can you believe it? There was no such clinic. My current section is called General Academic Pediatrics. We have 60 pediatricians in that section. And back then it didn't even exist in 1970. So that's
Okay.
how I got to Colorado.
So we're getting close to the telephone triage, but I think there's a little gap in here. So you're in general pediatrics, and then a decade or so later you're moving into that telephone triage. What's happening in between? What sort of areas of expertise, what interests did you have before you got into the telephone triage area?
I've always worked in primary care, and what I'm still working in and what I was involved in this morning and where I coach is in primary care. During those years, I got selected by Dr. Kemp, who coined the term and wrote the first article on the battered child syndrome, to be involved with child abuse. And I became director in 1972 of the child protection team there, which meant I evaluated maltreated children, went to court on them, learned a lot about that evil part of our culture. I worked in the emergency department for 5 years, but we'll get to that. I started a referral clinic on my own because of the behavioral training I had. It was a sleep problem clinic. The residents called one part of it a toilet train wreck clinic. Was eventually evolved into a diagnostic dilemma clinic, which I worked in until 2018. And that's where I saw all kinds of kids with recurrent headaches, recurrent stomach aches, unusual spells. It was really an enjoyable clinic, and it became a teaching clinic. So I had residents with me for most of the patients. So I did that. I did a lot of teaching. I ran a year-long teaching program for the Child Health Associates in behavioral pediatrics. Oh,
So a lot
it's
going.
great. So there was never a dull moment. There was no protected time back then, which means you didn't have time to write. You had to write on your own time. There were no secretaries. You had to either type or hire somebody on your own to do your typing.
So you have a lot of different things going on through all of that. When did you start getting into what we would view as telephone triage?
Oh, that's a nice story. I wrote a book called Pediatric Telephone Advice. It was published in 1980. It was the first book in the country, or I guess the world, on that. It came from the fact that in around 1975, when I was running this teaching clinic on ambulatory pediatrics, I decided, I don't remember why, but since I enjoyed taking phone calls from private patients I've cared for, and if I covered somebody's practice for them to make some extra money, I would, you get phone calls. In the Air Force, I got phone calls. And in the clinic, I'd sometimes, if I was the attending in the clinic, take the phone. And I decided the residents probably should know how to do this. It's a whole different skill set. It's veterinary medicine, right? You're strictly audio, as all of our listeners today appreciate. It's not easy. And you need patterns. And I always give credit to the fact I grew up, I never saw a television until age 16. So I grew up with the radio. So I did really well with just audio input. So I got the residents starting this within a month. Karen Stensrud, the head nurse, came to me and said, Bart, you can't do this. They don't know what they're doing. They're giving conflicting advice, harmful advice. I think she said dangerous advice. So I put a stop to it. And then whenever I had time over the next year, I would take the phone calls and jot down what I call decision points, which is really triage, and sort of develop patterns for different symptoms. And and about a year later, after collecting all these notes during the summer, I spent my spare time when I wasn't working putting together into a curriculum for residents. And I would give a copy. It was about 50 pages long, and I'd give a copy of that to the residents when they came on service, or maybe it was it was before they graduated. Anyway, um, somebody suggested I get it published. I had a lot of trouble getting it published. And fortunately, Little Brown and Company, a publishing company, a famous one that published To Kill a Mockingbird, among others, in Boston, was trying to start a medical division. So they published Pediatric Telephone Advice, this book that I was discouraged about publishing it by other publishing companies. Within 2 years, it was translated into French, Portuguese, uh, Spanish, and Japanese. It became very popular. It started being used in all kinds of pediatric offices, and this is 1980. And I did update it once later on in that decade, but then I pretty much put it on the back burner.
Okay. So that's sort of the structure behind triage and the protocols as it's forming for you. How'd you get involved in nurses and nurse call centers and bring the those protocols there?
Just from my good friend, still my best friend, probably Steve Poole, who was head of the emergency department at Children's. There were four of us, only four of us that ran the emergency department and another hospital's emergency department that helped with referral patterns. Steve would have focus groups quarterly with pediatricians in different quadrants of the city and do needs assessment. He always wanted to help people in practice. He had been in private practice for 5 years in a practice down in Littleton. So he understood the hardships of practice. And this particular November, it was a terrible flu season, and he came back and said, the docs, by name, I could name some of them, but why do that? That this is nighttime calls are killing them. And some of the listeners may not realize that back then, if you were on call for your group or your 2-person group or your 5-person group, you got calls randomly through the night. You could count on not having a good night's sleep. You would be aware, and some people, like myself, getting a call from a parent in the middle of the night, even though I thought I'd done a good job, um, I always worried. I had trouble getting back to sleep, and some people have more trouble with that than others. So they'd have to go to work, sleep deprived the next day, have long hours because of this influenza season. And so they said, they asked him, and if some way the ED, because we were seeing their patients anyway, couldn't we take the phone calls too? That would be easy, and we're up anyway, and we're covering the ED. And he agreed to that, and he came back to tell the four of us, that we were going to start taking calls for these 10 docs. And one of us said, "How are we going to do that?" And he said, "Oh, Bart wrote that book, Pediatric Telephone Advice, and the nurses can take them. I've got permission from the head nurse that as long as they have protocols, she would allow their emergency department nurses to take these phone calls. And you'll be in charge, Bart, to train them and monitor their performance." So that's
Oh, you were volunteered.
volunteered again, like I was, volunteer for child abuse.
And what what so the book was written in 1980. What year was this approximately?
88, 88.
88. So the book had been there for a while, but now Steve promised this service and put you down this path. How did that go? How did that work out?
Well, it was interesting because we had to prove something, right? We had to prove that it was safe. This was not nurse territory. These docs were taking a chance, and they told me so. Some of them did, but they were desperate. Um, so I took this very seriously and really monitored, looked at log sheets every morning, um, discussed cases with them. We didn't have a nurse manager back then, as it were. It wasn't really a call center. It was whoever the nighttime nurses were. Um, we ended up proving that we had a really good system. And 1993, we published an article in Pediatrics that really just changed everything. It was describing our system, our after hours coverage of pediatricians in Metro Denver by 1973, 5 years later. Actually, it was through 1992 that we had data. Um, we were covering for 93 pediatricians. We had not had an adverse outcome. We had, I mean, the community pediatricians and their families just loved this. We couldn't run into somebody's wife without them bringing up the fact that this had changed their husband, or there weren't that many women in pediatrics, so forgive me for saying that way, but no, it went extremely well. But anyway, publishing this article, lead article in pediatrics, we started getting phone calls and from pediatricians, I'm sorry, from other children's hospitals, and started collaborating with them. Um, we
So
got
what
involved with,
format?
go ahead, yeah.
So if they're asking, you have the book from 1980, and I'm guessing you probably started with something like that when you're working with the nurses in the late 80s. What format had evolved to when the other children's hospitals were saying, "What do you have?" You know, they're looking for both the process from you, but they're also looking for that content.
Yeah, thank you for bringing me back to the reality there. Yes, within a month, I realized that book, and if any of you have it, you can see why I say this. You could not find the protocol. It was laid out well, it was organized, it had sections, but to flip through and find the particular guideline when you needed it was next to impossible. So um, it was just a normal sized little small book. Um, and also, the triage just wasn't deep enough, wasn't refined enough. So I started listening in to nurse calls. I started to asking for advice from them, and we had lots of meetings. And oh, probably within 6 months, I had the top 20 calls, and you know what those are: vomiting, diarrhea, constipation, cough, colds, so on. Fever, that's number one. Fever, never forget that. Shouldn't be number one. But anyway, I had single page versions of the those top protocols, and I kept adding them and creating more of them in a 3-ring binder so that we had something that worked much better for the nurses.
Okay. And so was that, did that binder then, as it grew, is that what you shared with the other hospitals?
Oh, I didn't share anything until, well, 94. So I was doing that from 88 on. By 94, I had something really good. And when we had interest, then I really redesigned everything, got very serious. I started my own publishing company called Decision Press. And I would go to like an Office Depot equivalent and have these expanded, or I think 90 protocols um, printed there in bulk. And I'd get these big cartons and bring them home, had them punched beforehand with 3 holes, would get three-ring binders at another site, uh, bought packaging boxes at another site, and Mary, my wife, and I would on the weekend put these together, and with she typed up the address labels. And anyway, we were running a publishing business on weekend out of our home and selling them out of our home. And I would mail them on Mondays or Tuesdays, whichever day I didn't have to go into work early. I'd stop at the post office at 8 o'clock when they opened with a bunch of them, make multiple trips to the car. So we had a publishing company going from the year 1994 through the year 2000 when the American Academy of Pediatrics came to the rescue, wanted the book to publish the book, and I glad to give them publishing rights, and we closed Decision Press within a couple of years.
Nice. And so that was the Pediatric Telephone Protocols book that is
Yeah,
sold to the
now is
AAAC.
in its eighth edition. The AAP published its eighth edition, so we self-published seven editions.
And now it's on the 18th.
Yes, yes.
Nice. So if I am following the timeline around, so we're talking 80s, 90s, and so you start having these things called computers that are out there moving into businesses, moving into hospitals. How did the protocols migrate their way into software? Because certainly these days, I would imagine most of the people on this call interact with the protocols in software, not in the book format.
It's really interesting that that article I talked about was published in Pediatrics 1983. People in business became aware of it. Uh, and their software vendors were wherever they came from were aware of it. And so it wasn't hard to find a software vendor. They found me. But what's interesting also in that year, this was 1994, uh, we needed a bigger boat. Our nurses, and we would have one, sometimes two on in the emergency department taking calls, were recording, documenting their calls in three-ring binders by either alphabetical by practice or by physician for the about 50% of pediatricians were in solo practice back then. Now it's not even 10%, maybe it's less than that. Anyway, and then we would fax out the call documentation to the offices every morning. We had an aide do that. So we needed a bigger boat. And I knew we needed software, and Steve agreed and had three software vendors show up quickly. I don't know how we got the word out, um, and chose one in Phoenix. I liked the people there, and we really hit it off. It's called National Health Enhancement Systems. I then that summer went down every other weekend for 2 or 3 months and worked with a nurse down there, Carol Becker, who was just great because they already had a program, but they didn't have any pediatric protocols, and their adult program we can come back to later didn't work that well. Um, and some software geniuses. And together we put together a format including targeted care advice, which people listening know what that means. You click on a question and very specific appropriate care advice for that positive question comes up on the screen. That started in 1994 down in Phoenix, and that was released. And with that release, even though the adult protocols didn't change, they ended up getting all these children's hospitals that were interested. Um,
Okay. So your call center was using it, other children's hospitals starting using it in
and major
software.
medical centers were too. They got a lot of business from having the best set of protocols out there.
Well, okay, I'm going to take us to another stage in this journey. So you mentioned about how their adult protocols had issues with them. So that probably brings in another key figure in this growth. So your business partner, Dr. David Thompson, how did you wind up connecting with him, working with him? Kind of what's the story behind that that led to the that Schmitt-Thompson name that so many of us know?
That's all right. I've worked with David since the year 2000s for 25 wonderful years. He was the perfect match for me. We're both engineers, both grew up in Chicago for what that's worth, both Eagle Scouts, lots of common interest, both think a lot alike, both very demanding, precise thinkers. Uh, Again, all about that engineering background, I think. Um, it's interesting. David was chief of pediatrics in, I don't know how long, at a community hospital in the Chicago area, a big one. And they were using this NHES software I told you about, where the adult protocols were static, out of date, I guess. And I mean, I didn't want to take them on. I was asked to.
And he was chief of pediatrics there because he's his
Oh, I
background.
said, forgive me, David. No, David was chief of emergency medicine there.
Okay, that makes more sense.
Big yes. And they were getting referrals based on these protocols. And we always got feedback, negative feedback. That's kind of feedback you usually get from nurses to some degree about the adult set that they had. But David got involved and he clearly was outspoken and voiced his concerns about things in the adult protocols starting in, I don't know, probably the year before he and I joined forces, maybe before that. But anyway, he was a known entity and he came to a conference, I think, also where we met. Anyway, in the year 2000, by a twist of fate, I went from being exclusive by contract with this company to no longer having an exclusive license, being non-exclusive, and knew I could, you know, add an adult author who could really go in the direction I thought we should go. David was more than interested. He was the perfect choice. Um, about 80% of my protocols were full age range, right? Cough, cold, all those things we talk about, those symptoms are adult and pediatrics. So working with what I had and with his knowledge and experience, and I think within 6 months, he had an adult set of protocols or guidelines. And we now had a full age range set, and he kept building his content and topics. And the big, much more technically savvy, computer savvy than I ever was. But the major breakthrough that David brought us was in the year 2002 when he put my content and his into an Access database, which allowed for some kind of easy interface with other software vendors. So things really took off thanks to
So you
David.
started having other, who were some of the other software vendors that came on early on there? All everyone knows from this is our 10th anniversary of Clear Triage, so it wasn't Clear Triage back then. Who did you start working with to bring this to
Access
people?
Health, it was Microsoft. No, I'm sorry. It was LVM. It was Epic. IntelliCare.
Epic was probably, we can joke, but that Epic was a small, I mean, they were just one more EMR company at that point, as opposed to now when they, as many of us know, own the hospital world. So they were early in their path and
Yeah,
licensed the protocols, it sounds like.
I can't remember the date, but I remember I flew into Chicago with our business manager, Sue Riffle, at that time, and David drove us up to Epic's campus, and we spent the day there meeting with Epic and seeing their their Epic Galaxy, as they call it. I think we've had a wonderful relationship with Epic. I think we're with maybe 16 software companies at this point.
Nice. Well, so you've got software, you've got the protocols in software, lots of software companies using them. Looking back, did you ever imagine as you were getting started in this that the protocols would have the impact that they have had on nursing, on healthcare?
No way. And I don't think David did either. Let me bring people up to date on the perspective. We currently cover over 95% of call centers in the US. Some people say there's 400 of them. I don't know. We cover 8 of the 9 Canadian provinces. And of course, their call centers cover everybody in that province. And I want to come back to that later. We have over 800 guidelines, after hours guidelines between the two of us. We take over 40 million calls a year. You take them, the nurses in this audience. Over 20,000 nurses, it's estimated, use our content for decision support. The American Academy of Pediatrics, I've already told you, took on the protocols, reviewed them. They don't publish things they don't review. And in the year 2010, they took on my symptom checker. In the 2016, they took on all of my pediatric care advice handouts. So the AEP is sort of from this pediatric standpoint is very much in sync, and we're in sync with them in terms of policy and procedure and standards of care. So that's where we stand. No. And did I ever think that would happen? No.
Why do you think the protocols have become so successful and so widely used?
They work. They work for doctors, they work for nurses. They work for nurses, I think, because nurses approve them. And the reason nurses approve them is because we've always used nurse feedback to make them better. And we've always recognized how good nurses are at this and how important their judgment is. And as they tell us, or they remind us, they have to decide which protocol to use. We can't tell them. And then they have to decide which question really applies to this particular individual they're assessing. And they have the final judgment on disposition. Our protocols are a checklist to prevent them missing any red flag symptoms. They are guardrails. And Kathleen Martinez wrote our newsletter last quarter in which she said that this is the winning combination, right? Nurse judgment and evidence-based guidelines. But I think something else, at least in office practice, and I think call centers too, there's usually oversight by physicians, and physicians trust physicians. And the fact that these are written by David and myself, that we have a combined experience of 70 years in this crucible of getting the right patient to the right resource at the right time, and sort of living and breathing triage, sometimes one case at a time, one call at a time. We have a vigorous QI program at our call center where I was medical director for over 30 years. And every week, and now it's every 2 weeks, we review calls and we learn from them and we make changes in guidelines if there's something that could be worded better, or if a triage statement should be at a higher disposition level. So having physicians as the initial writing team is very important. But I think the other big factor is something I've always had as a perspective is I want to know what other people think. If you work in an academic environment, there's always feedback. There's constructive feedback. It's expected. There's all these evaluations we do of medical students and residents and other people we work with. it never occurred to me how much that would apply to our adult and pediatric clinical content. We invite feedback, and it turns out that nurse feedback from nurse managers and nurse educators and call centers has quickly become the most important continuing quality improvement you could ever imagine. It's just a landslide of good thoughts and observations that you can't make if you're not the user. So users are telling us every year things they would like, things that they think could be better. Sometimes they have the answer to make it better, but even the questions are good. And I learned a long time ago from a colleague that complaints are a blessing in disguise. They're a gift. And my gosh, the gift we've received from 20 children's hospitals every year or more give us feedback. Probably 30 or more full age range hospitals or medical centers give us feedback every year. And then we get random feedback from other nurses who are particular about making these perfect. And so we keep changing, we keep evolving, and it's all about nurse commitment.
So, let me step back just a bit. You talked about the trust in having the physicians that have written these and so on. You talked about you and David writing the protocols. Um, but it's not just you. Let's go back to just the pediatric side. It's not just you anymore. You now have a team of doctors and nurses that are involved in this. Can you talk?
Yeah.
And I'm looking at the time here, so I will add that. Can you talk briefly about um, we're at quarter till.
Uh,
Um, can you talk briefly about some of the other people on your team and what they've brought to the content and to the process?
sure. Look, I've never been alone. I mean, since 1988, I've worked closely with nurse managers in our call center, and we cover 550 pediatricians, Montana, Wyoming, Colorado, New Mexico. And we have 50 on the average telehealth nurses. And there's always been feedback from them. And I really counted on that. But in the year, and I select, there was the smartest nurse in our call center who was almost a medical student, but then decided to go into nursing. Kelly Massaro, she was the best decision I ever made is I hired Kelly part-time in 2004. I checked that with her yesterday. She she reviews everything I write since 2004, and she does the data entry, and she keeps me reality based. Um, we added part-time hire Lisa Swerzik from St. Louis Children's Hospital, a nurse educator there in 2007, I think I said. And she handles all the feedback, answers what she can, routes it to whoever is the best person to answer it, calls meetings when we need a group decision on how to best answer it. And 3 years ago, I hired part-time again, two emergency medicine physicians, and just they're working out wonderfully. And I needed somebody to replace me at some point, and that time is getting short. Sam Wang has become medical editor of the pediatric triage guidelines and protocols. And Julia Bruckner, who also has a degree in journalism and is also an emergency medicine physician, is a medical director of the pediatric care advice handouts. So that's where I am. And we have a great team going. We have two data entry people in addition to those. We have Teresa Haggerty, one of our very best call center managers. And I want to mention also Kathleen Martinez and Jamie Klein, two other great nurse managers who taught me so much, if they're listening. But Teresa is a consultant to any children's hospital that wants a consult on how to improve their efficiency. She's excellent at that. She was our nurse manager for almost 20 years.
Oh, good. Oh, you mentioned two things I want to dive into, but let me touch on a first one because one of them came in as a question. Um, so Karen Lafferty is asking in our question group, she said that you've used she's heard you use protocol and guideline, and you just did that in that last piece you were talking. What's the difference between the two? What um,
Hmm.
does that distinction have any? Does it matter, or is it the same thing?
Thanks. Thanks for the question. I don't think it matters anymore. Um, our protocols work. They're mature. They've been tested in time. They've got a lot of mileage. Uh, there was a time when nurses didn't like the word protocol, and maybe some docs didn't either. It sort of implied that you had to follow it exactly, and that it removed nurse judgment, which never intended. So we changed the name of the after hours ones, used mainly in call centers, but not always, sometimes used during the day, to guidelines to meet that concern. I think it's gone away, and you can call them
Right. I mean, if you,
protocols. What do you think?
I mean, at this point in time, AAACN's standard terminology for it is decision support tools. So you really are authoring, and the people that you license to, such as Clear Triage, are creating a decision support tool. Protocols and guidelines seem to be just two words for the content that exists in that support tool. But I think that the key part, and it's what's in that AAACN word, is decision support, not a decision-making tool, is there to support the decision, the skills, judgment, experience of the nurse.
Exactly. This is not something that can be used by other than a nurse or a physician.
So then the other piece that struck me as you were talking about your team is you talked about Julia Bruckner working on the handouts. So you have other content besides the nurse triage protocols that your team is responsible for. Can you talk briefly about what those different things are, how they relate to each other?
Sure. I've been writing handouts since the 70s. I wrote them for my own patients because I couldn't cover everything in the time allotted, even when we had 30-minute visits. But anyway, um, I had a couple of hundred of them in the early 80s, and they became the pediatric advisor, which some of you are aware of. Um, they are used. We now have, both in the adult and pediatric side, handouts that are matched to almost every guideline, and they're available at the end of the call. To shorten the amount of time that you need to spend on giving care advice. You can give the high priority essential care advice live. You can't give it all live. It's impossible. So that shortens call times. The symptom checker I wrote in the year 2000, when websites came on the scenes and pediatric offices started to have their own website, and some community pediatricians came to me and said, can't you write something for parents? These protocols that the nurses are using are working great. And anyway, I wrote it. It's updated yearly. The AAP has it, and it's for self-triage, self-care by parents. It's safe. It's had some studies done. Um, it potentially, for parents who use it, offloads half of the calls that a nurse would get. So that if you put these together, symptom checker first, less calls to the nurse, nurses, less calls to the doctor, and then the handouts, shorter call times, you can have a much more cost-effective and efficient system. So that's as brief as I can be.
Okay. I'm looking at a question here that I think would be interesting to talk about. The Amber here says that she's a nurse manager of a remote nurse triage department. They've piloted a new initiative for in the ambulatory space, but they're having some pushback, lack of buy-in from providers, and they're concerned about liability and legal concerns, uncomfortable with the nurse following a protocol. Um, what advice would you have? Yes, you look at all your time, the different time you've talked to different providers. What advice can be shared with with her providers to ease their hesitancy?
These have 12 research studies behind them. Several of the studies looked at safety. Um, it's this actually, we actually did a concordance study. Two of the studies were on concordance of nurses using these protocols and with getting their making safe decisions and making uniform decisions, uh, and with doctors being the judge of that. And then we did a concordance study of three pediatricians um, taking calls. These were calls with a actor, and the doctors were not in concordance. Anyway, doctors in the middle of the night, short of sleep, are more risk for making a mistake than nurses. The concordance studies suggested that. Um, we've had a multi-center study at 5 children's hospitals where the results looking at safety and uh, there were no adverse outcomes, and there were like 1 in 600 under referrals. Um,
Yeah.
I don't know. They've been around. We've got over. First of all, mine have all been reviewed by subspecialists in pediatrics. Many of David's have too. We've had reviewers, physician reviewers in large numbers, and medical directors at call centers review them. Uh, we just don't hear about. I,
Yeah.
I get. I've had over the years requests to be an expert witness. It's always about a case where a nurse didn't use or somebody in the office did not use a protocol. Never a nurse who did.
I think that yeah, I will leave it at that. I'm going to we need to be wrapping things up here. So I'm going to go two sort of broad questions. What are you most proud of, and what do you wish you could have done differently?
Hmm. That's a really hard one because I've played a lot of different roles in life here. Um, and I'm very proud of the hundreds of residents who have been part of their training, and I still see them, and some of them give me feedback about different things. Um, but what I'm most proud of is helping to get after hours call centers on the map and accepted as part of healthcare systems, and getting pediatricians who used to be, when they were on call, would get interrupted so many times at night. I can remember being on call and driving home from the hospital. I had to have quarters and know where the phone booths were right when my pager went off. Um, it, it just never made sense to work a full day and also be on at night. And because you got to keep in mind, the offices are open, let's say, at best 9 hours a day. That's 45 hours a week. There's 170 hours in the week. So there's, I don't know, 60% of the time, if my math is right, or maybe more, is after hours. And you just, you've got to have somebody who's really good and is working a shift and is fully alert uh, covering those hours. I'm just so glad we could take that burden off of the pediatrician's plate. And I tell you, I go to a retired doc luncheon, and I have docs from that era, the 90s and the early 2000s, still thank me for that breakthrough and that seismic shift in who takes calls during the middle of the night. And of course, the nurses who are involved in that, who have that role, love it too, because many of them want to work remote. We went remote in the year 2000 with our nurses, special training and phone setups. But to be able to work at home and treat 5 patients and help 5 parents an hour is a wonderful, rewarding experience for nurses. You asked about regrets. I should have gone after it in a more serious way, finding successors before I reached age. I found Sam and Julia when I was 85 years old. But what I did wrong, I was looking in the prior decade, but I was testing and training and hiring part-time primary care docs. Triage, which is the backbone of these decision support tools, getting, again, as my air traffic controller friend says, getting the right aircraft on the right runway at the right time. But anyway, uh, it's about triage. It's what you do in emergency medicine. I've shadowed Sam in the emergency room. You walk in a room, and as he said, within the first minute, you make a decision. Am I going to admit this patient? Does this patient need procedures of some kind, oxygen, lab tests, or is he going home? You know that right away. It's this quick decision making that's required when you work in an ER. And it brings back my 5 years in an ER. And I should have contacted Mark Roback, the head of emergency medicine, who helped me find find Sam and Julia. So that's my regret.
Okay. Well,
Waiting for them.
luckily it's a regret that you have addressed at this point in time. Is there anything else that you would like to share with the audience at this point in time?
Uh, if you're interested, I'm in relatively good health. I'm a lifelong learner. I have a restless mind, so watch out. I still teach. I'm still very involved with the people that are writing your protocols. I live with my wife in a home we bought, very peaceful home that we bought in 1970. So a lot of things have been stable. And I'm going to tell you, we've got 4 kids, 8 grandkids, 1 great-grandchild, and I have one of my grandsons is entering medical school next year. After five
Yes.
years as an Army medic, he's going to be an emergency medicine physician. So he'll know more about triage than I do.
So the cycle continues. Well, Bart, thank you very much for your time today. We really appreciate it. We're getting a lot of thank yous and comments in here, and I apologize. There are a few questions in here we haven't been able to answer, but at top of the hour here, I do need to wrap this up. So thank you very much for your time. Everyone, thank you for joining.
You
This
bet,
is the
man.
last of our 10 for 10 webinar series. We have gotten such positive feedback. We are going to continue this on a less regular basis, maybe quarterly. And so we do have 2 webinars coming up in November with Liz Greenberg, past president of the AAACN. And in February, we're going to have a great conversation with Catherine Caney. So please feel free to register for those webinars. Thank you all for joining us today and have a great rest of your day.